advent of what we're still calling new drugs. So thalidomide was the first one, and that clearly has led to a shift really from true chemotherapy used initially, what was VAD, where people would lose their hair and throw up and have all these other problems, to a therapy where we can consistently and chronically treat patients. And I think it's the chronicity of treatment that has been one of the things that has made a significant difference. And shown here, is there a pointer, Jenny? All right, okay, well, I'll use, all right, here we go. So this was the first chemotherapy that I was talking about. The chemotherapy, these three chemotherapeutic agents. And if you look at the blue, at the green, that's a percentage of patients that are in a complete remission. And you can see that that's in the single digits. And if you look at the blue, that's overall the percentage of patients that have had at least a 50% reduction in their disease burden. And that's just around 50%. And we jump to these later combinations here. And now you can see that we're close to 100% response rate with certainly over a 60% complete response rate. And this has really revolutionized everything. And the other thing that I want to point out, because I think this is going to be a recurrent theme through the day, is that most of these regimens, without actually knowing what they are, have 3 drugs involved in them. So this concept that 3-drug therapy is probably better than 2-drug therapy and therefore also better than 1-drug therapy is important. So, you know, the one thing that I think is very different about myeloma compared to a lot of other malignancies is that it's very hard to understand what the disease actually is. I think, you know, if a person has a lump on their mammogram and they get a biopsy and it shows breast cancer, they've got breast cancer. If a person gets a bronchoscopy and it shows lung cancer, they've got lung cancer. But you can have a bone marrow that shows plasma cells and not necessarily have myeloma. So I've put a few questions here because I think it really will be a theme throughout the day. And the question is, what exactly is this? Is it just an increase of plasma cells? Is it a disease of the bone marrow microenvironment? Or is it a disease of genetically altered plasma cells? And the answer is yes. It's a little bit of all of that. And I'll try to go through some of this. This is a slide that really brings to this whole concept. We think that cancer starts from a single cell, and it probably does. And so you go from 1 cell to 2 cells to 4 cells. But what this schema is showing is that as you progress from just a normal plasma cell to MGUS, which is the pre-malignant condition, to smoldering, to myeloma, to plasma cell leukemia, you can see that you're acquiring multiple genetic hits that is ultimately resulting in a much, much more complicated disease, as shown on the bottom here by the increased diversity of these cells. And this is a very diagrammatic, hopefully simple explanation that basically says that although you're starting with 1 cell, in the end, you're coming up with multiple ones. This is a little bit more scientific in terms of what's actually happening, but again, the concept is the same, that if you look at the very early pre-MGUS condition, that basically the disease is very, very homogeneous. And even when you get into the MGUS stage, there really isn't much there. And as you progress, you're acquiring a lot of these genetic hits so that when you get to multiply relapse disease, the disease looks very, very different than what it did when it initially started. And some of these come up and some of these go down, and that's really represented in this graph. This was actually a patient that was treated, I think, at Mayo in Scottsdale. And what they did is they actually did DNA sequencing of the entire malignant plasma cell at various time points throughout the patient's disease. And so you can see that at diagnosis, they primarily had this red clone with a little bit of the orange and the green. And then initially they were treated with Revlimid and dexamethasone. And they went into remission, and it was still the same. And then the first relapse, already you can see that the red and the orange sort of shrunk, and the green increased. And then after that, they relapsed again and were treated with carfilzomib, but now you can see that the green shrunk and the orange increased. And then after that, they were given Velcade with another agent, and again, you can see that the pattern shrunk again, changed again with even more increase of the orange and some increase in the red. And eventually, the patient relapsed and developed a plasma cell leukemia, and the predominant clone that was there was this blue clone that, if you actually go back to the original diagnosis, wasn't even there. So this, I think, really exemplifies what actually happens in myeloma, this concept of clonal evolution or clonal diversity, which schematically is shown like this and biologically is exemplified by the kinds of things that I showed you in the first graph. So I told you this is an increase of plasma cells, but it's also an increase of plasma cells that have acquired genetic hits. Now, the interesting thing that a lot of patients ask me, certainly patients with smoldering myeloma or even newly diagnosed, how long have I had this disease? And none of these things just sort of pop up overnight because you got mad at your children or didn't pay your taxes or something. These things have evolved. And this is actually a very interesting study that was done in Sweden, where Ola Landgren, who is now at Sloan Kettering, they had banked a lot of serum on patients. And what they actually did is, as patients developed myeloma, they went back, and for those patients that actually had serum stored, they looked to see if they could detect an M spike. And what you're seeing here is that in some patients, as early as 8 years prior to their diagnosis of myeloma, there was evidence of an abnormal M spike in their disease. And that telling you that this is a very slow clonal process that evolves over time. Actually, I showed you this already, so I'll skip that. And what we're seeing, I think, as you make this transition, that you go from MGUS to smoldering myeloma to active myeloma, that even now an area of significant research is how we are now subcategorizing smoldering myeloma. And it's now being categorized into 3 different categories. There's a high-risk disease where if you can see the probability of relapse goes up very, very rapidly in this patient population. And then there's this intermediate group, which has a slightly slower slope. And then there's this third group, which is called the low-risk group, that actually has the same slope as patients with MGUS. So you can see that these 2 lines are basically parallel. And in fact, we now talk about this as low-risk, intermediate risk, or high-risk smoldering myeloma. And what we can now do with the advent of drugs like Revlimid and other non-chemotherapeutic drugs is begin to treat earlier on in the disease. And in fact, there is a lot of data to suggest in the context of a clinical trial that treating the high-risk smoldering myeloma may have a benefit for the patients. As you can see here, that's sort of the rate of progression with these different types of myelomas. So that, I think, is sort of at a big level. And coming down a little bit, then the question becomes, what are these genetic abnormalities that patients can acquire or that the disease can have over time? And as you know, myeloma, or rather a plasma cell, its normal function is to make antibodies. And antibodies are immunoglobulins, and immunoglobulins have a heavy chain and they have a light chain. And so IgH stands for the immunoglobulin heavy chain. And that immunoglobulin heavy chain, the chromosome upon which that immunoglobulin is synthesized is chromosome 14. So I don't think it's a coincidence that a lot of those translocations there involve chromosome 14. In fact, all of those specifically at that point. And so you can see that a lot of things that are happening to the plasma cell are obviously involving the heavy chain of the immunoglobulin synthesis. And there are a variety of chromosomal rearrangements that we typically see in multiple myeloma. And in terms of the IgH translocations, the ones that have the asterisks on them are the ones that tend to be considered high risk. The other side of it is just the genomic imbalance, the fact that the actual DNA itself can either acquire more DNA or actually get rid of DNA. And if it acquires more DNA and more chromosomes, it's called hyperdiploid. And which actually in myeloma is a good prognostic sign. And if it gets rid of some DNA, it's called hypodiploid or non-hyperdiploid. And that actually is less favorable. And then what has also come out recently has been an addition of chromosome, the long arm of chromosome 1, which we call Q, so it's 1Q plus, and the deletion of the short arm of chromosome 17, which we call 17p deletions. So the asterisks are the ones that tend to be slightly higher risk. And why are they higher risk? They're higher risk because if you look at the probability of survival, it is slightly shorter. So in general, an 11-14 translocation is considered to be a good risk chromosomal abnormality or translocation. Deletion 17, and this slide is a little bit old, used to be considered a poor risk chromosomal abnormality. But this is one of those situations that now that we have the new drugs, thalidomide, Revlimid, and everything else, that's sort of eliminated the negative prognostic factors of chromosome of a 13 deletion. And so it's really no longer that. And then in the black, you can see that there are some of these other chromosomal translocations or abnormalities that are still considered relatively poor risk. And unfortunately, it's correlated with survival. So this is getting into something that's a little bit more complicated, but the bottom line is the same, that as we understand, and without going through every individual one of these, but as we understand more about the biology of the disease, this is translating into the clinical implications of that. And without belaboring this point, you can see that these curves are really separating out a lot more. So there's a group that is really poor risk, and there are groups that are getting better and better risk. So for those of you that can't see it, the one on the top, it says no deletion of 13q, no translocation of 414, no deletion of 17p, and the low beta-2 microglobulin. And in the pink, which is the last one on the bottom, or I'm sorry, actually this one right here, says either, the gray, says either 414 or 17p deletion and the low beta-2 microglobulin or a high beta-2 microglobulin. So it's the chromosomes that are changing that. Some newer data that came out of Arkansas, which you may or may not know is really one of the biggest centers that has done a lot of work in myeloma, has been to take these chromosomal abnormalities and translate them, or to really take them one step further and now look at molecular abnormalities. So as you can see here, well, I guess it's probably better if I stay out the microphone. So these are some of the chromosomal abnormalities that we've been talking about already. But what this is, it's this gene map. And in general, the way you read these things is things that are red means that the genes are up, and things that are blue means that the genes are down. So you can see, if I can get this to work, that in this case, in this MF group, there's this cluster of genes that are red. This group here, CD2, has a cluster, there's a cluster, and it sort of matches through. And what they've been able to show is that certain ones of these translocations tend to be associated with certain gene rearrangements. So for example, the 1114 translocation tends to be associated with genes that overexpress this protein CD2 as well as CD1. And the 1416 translocation tends to be associated with this protein right here, and so forth. And why is this important? Because I just finished telling you in the earlier slides that there are chromosomal abnormalities that are poor risk and there are those that are good risk. But what's also coming out is that there are certain chromosomal abnormalities, such as a 414, if I can get to here, get this going. Okay, so this 414, that if they don't have these genes expressed, are actually not as bad as if those genes are expressed. The reasons why we traditionally call them bad risk is because these genes tend to be expressed in that group, but you can also have a 414, for example, that doesn't have those genes that are expressed. And that has actually translated into these clinical survival or risk stratification. So many of you may or may not be aware of the international staging system. So the international staging system is basically a clinical staging system that was developed through a retrospective study primarily done on patient samples from the 80s and 90s, where they looked at over 20,000 patients, and they looked at the clinical characteristics that these patients had, and really came down with two criteria. One is beta-2 microglobulin. So beta-2 microglobulin is a protein that is present on the surface of plasma cells. So the higher the beta-2 microglobulin, the higher the disease burden, or the more aggressive the disease burden. The other aspect of it is that it's not secreted by kidneys. I'm sorry, it is secreted by kidneys. So when the kidneys are not working, that number goes up, and obviously that's not a good thing. And the other aspect of the ISS is something called serum albumin. Albumin is the whites of the eggs, but it's also a protein that's made in your liver. And with chronic illness, whether it's myeloma or malnutrition or anything else, your albumin production goes down. So you can imagine that good risk or stage 1 disease is patients that have a high albumin and a low beta-2 microglobulin. And in contrast, high risk disease are patients that have a low albumin and a high beta-2 microglobulin. What the Arkansas group did is they incorporated in this MyPRS, which is this gene expression profiling. So MyPRS stands for Myeloma Prognostic Related Score. And you can see that even within this quote-unquote good risk disease, you can separate it out based on the genes into patients that have a more favorable versus a less favorable outcome. And that translates into differences both in terms of survival as well as progression-free survival. And in fact, there is now a revised international staging system which doesn't take into account the molecular abnormalities that are there, but does take into consideration the chromosomal abnormalities. So remember, the chromosomal abnormalities are the T414 or 17p deletion, not these molecular genes. So, you know, a question that I think all of us ask, and as we physicians get, is, you know, doctor, am I in remission? And, you know, and the question, and the response to that always is, it depends on how you define it and what actually is remission. So this really is a slide that tells you where we are and talks about how we need to start looking at this. And this is an exciting slide because 10 years ago, we would never be talking about this. Basically, what it's telling you is how deep of a response you get is depending upon how many tumor cells you actually get rid of. And if you can see this number on top is 10 to the 9th, so that's 1 trillion cells. And it's believed that at presentation, people probably have 1 times 10 to the 10th, so that's 10 trillion cells of myeloma. And if you get down to a complete remission, you're still down to about 10 million cells. And you can see here that that's a complete remission, and a stringent remission is slightly deeper. And then we're entering into the range of minimal residual disease that's detectable, and then there's minimal residual disease undetectability or negativity. And as one can imagine, without having to be a biologist, that the deeper the response, the longer it takes for the disease to actually come back itself. And this is sort of a theoretical graph. This is more real life without talking about MRD, but you can see here, this is data that was published by the Spaniards, and these are patients that achieved a complete remission. These are patients that achieved VGPR, which is a 90% reduction, and these are patients that had either stable disease or progressive disease, and this is the amount of time that they're in remission. So you can see if you go over to the 50% mark, the patients that achieved a complete remission are around 7 years versus patients that achieved a partial remission are around 4 years versus less than a year for patients that had less than that. And again, this concept makes sense, and obviously that translates into overall survival as well. But this is a field that is also rapidly evolving, and I think one of the areas in which we've begun to really learn this question, I'm sure this specific study will come up more throughout the day because it's a very important study, is how do we incorporate, first of all, new agents, but what I'm going to talk to you about today is the whole concept of minimal residual disease testing in understanding this. So this was primarily a French study that was done of 700 patients, excuse me, that got Revlimid, Velcade, and dexamethasone. And then, for 3 cycles, and then they were randomized, and they got their stem cells collected at this point. And they either went on and got a standard autologous stem cell transplant, followed by more RVD, followed by Revlimid maintenance, or continued with RVD and then Revlimid maintenance. And they did MRD testing at these time points. And this testing was done initially, and there's several ways to do this. One is by flow cytometry, and the other one, which is looking at the cells, and the other one is a molecular testing, which is looking at the DNA that is expressed on these cells. And what we know now with MRD testing is that you can test, and depending upon where you set that limit, obviously you're going to get a very different answer. And so what this is showing you is that this is showing MRD negativity less than 10 to the 6th, which means that there is less than 1 cell per million. And this is MRD testing between 1 in 100,000 and 1 in a million, 1 in 10,000, 1 in 100,000, and less than 1 in 10,000. Okay, so these are still levels where by the classic lab works that you guys get all the time, all these patients are in remission if we're thinking, I mean, at least they should be if we're thinking about these kinds of tests. But what this is showing, again, and it makes sense, but this is really the first time that this data is coming through, that the deeper the response, so if you have less than 1 in a million cells, your likelihood of staying in remission is very, very good. And in contrast, the more cells you have, the lower the likelihood is of staying in remission for a longer period of time. The other thing that this test showed, and remember, this study had everybody got the same chemotherapy, and then they were randomized to getting transplanted or not getting transplanted. What it showed, again, which is what makes sense, is that if you're MRD negative, which are the red and the blue, compared to the green and the orange, you do better than if you're MRD positive. But there's two other points that I want to make here. And one is that if you're MRD positive, so you still have residual disease, you do better if you get a transplant than if you don't get a transplant. And the second point is that if you're MRD negative, it doesn't matter whether you got a transplant or not, because your outcomes are overall relatively the same. So, the conclusions of this, and Greg actually specified that we had to stay on time, so I'm happy that I'm within the 25 minutes and I haven't gotten any weird signals from him, is I hope to have conveyed that myeloma is not one cell, it's a really complex disease that is constantly evolving. What the tumor microenvironment, and I didn't talk to you about that because I was afraid I was going to run out of time, but how the bone microenvironment contributes, how the clonal diversity, how the multitude of genetic hits, which may ultimately be dependent upon the initial treatment that you get, and I'm sure Drs. Badros and Wiesel will be talking about that, really all factor into how patients ultimately do, which I don't think is a coincidence to what Jenny said, that people treated at academic centers appears to have better outcomes than patients that don't, because of the way we approach this. And that this clonal evolution is a very interesting concept, and how we're ultimately sequencing all of these things in need to be factored in. That MRD negativity is a test that we are now beginning to use, not only for research purposes, but with clinical outcomes. And maybe there can be a discussion later as to whether people treat MRD positivity or not. I can tell you that I have some colleagues that do and actually go crazy once a patient converts from MRD. I mean, they call it, this is Keith Stewart, he said that he has MRD envy or something like that. I mean, he just absolutely goes completely crazy working up this 1 in 100,000 cells. And that transplant, and this is something that I think, in contrast to the people that are taken care of by Dr. Badros, who has been a believer of transplants since he was born and got rid of his diapers, in contrast to us at the university, at Hopkins, where we actually were less believers in transplant. But this French study that I just showed you showed such a dramatic advance and benefit to transplant that I think, I think transplant is here to stay, at least for now. So see, this is a heretical, you were right. Okay, thank you.